Hi everyone, this is Dr. Upali Nanda, Consultant Internal Medicine at Medeor Hospital. Today I would like to bring you some insights on diabetics with established cardiovascular disease. Let us take the example of a 53-year-old corporate executive diagnosed with diabetes 6 months back. When he came for routine checkup, he complained of weakness. His family history was positive for hypertension and myocardial infarction. He was a heavy smoker for almost 30 years, but he had quit 5 years ago and was trying to lead a healthier lifestyle. He did have a previous history of myocardial infarction 3 years back. Now, when the doctor examined him, he found him to be overweight with a weight of 92 kgs and a BMI of 30.7. His blood pressure was around 140/90. So the lab evaluation revealed a HbA1c of 8.4%, which is not a very good control for diabetics, with cholesterols on the higher side, and a eGFR, which indicates the kidney function test, being below the optimal level. So the drug history revealed that the patient was only on one drug to control his diabetes, which was metformin, 1 gram twice daily, along with other drugs for blood pressure, cholesterol, which he was taking, and blood thinners to control because of his previous history of myocardial infarction. So the primary goal of the treatment of diabetics should be cardioprotection, because cardiovascular disease is a leading cause of mortality and morbidity in adults with type 2 diabetes. Its onset is estimated to occur about 12 to 15 years earlier in people with diabetes. The excess risk for atherosclerotic cardiovascular disease in patients with diabetes has been estimated to be at least twice that of those without diabetes. A Framingham offspring study suggested that 2/3 of patients of diabetes have subclinical cardiovascular disease. And diabetes increases the risk of subclinical cardiovascular disease by 4.3 folds. And this in turn increases the risk of cardiovascular events by 2 folds. The vascular wall in patients with diabetes is well known to have advanced atherosclerosis. Now, several studies have been done to show what are the medicines that can be taken in diabetes which can decrease these cardiovascular risks and even renal risks. So one of these studies, which is the EMPA-REG study, has shown the beneficial role of the SGLT2 inhibitor empagliflozin in cardioprotection of diabetes, with reduction in all types of cardiovascular deaths, early reverse cardiac remodeling, and stabilization of coronary artery disease. Along with SGLT2 inhibitors, other studies like the Carmelina and the Carolina trials have shown the DPP4 inhibitor linagliptin, which has also demonstrated cardiovascular and renal safety in comparison with placebo, when it is added to the standard care in patients with diabetes who are at a high risk of vascular complications. Now, a combination of the SGLT2 inhibitor empagliflozin and the DPP4 inhibitor linagliptin is available as first-in-class treatment for diabetics. And this combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight reduction and weight gain in patients with high baseline HbA1c level, together with cardioprotective benefit in patients. So our main goal in diabetes should be patient-centric approach. Number 1, cardiovascular protection. Number 2, microvascular protection. Number 3, weight reduction. Number 4, to reach a glycemic goal with little or no hypoglycemia. And number 5 is a convenient dose schedule. Most of this management approach can be achieved with the help of SGLT2 inhibitor and DPP4 inhibitor, a combination of both, or either one in combination with other drugs which are available for diabetes. Therefore, these new drugs should be either used as add-on therapy or as first-line treatment in patients with diabetes with or without established cardiovascular disease. I hope this talk has been helpful in guiding you in the treatment of diabetes with established cardiovascular disease. Thank you.